questions. So posture, we probably don't need to assess on every patient, isn't it? It's like if a patient's got only pain with movement or lifting or loading, just look at that. We don't probably need to worry too much about the posture. But if it's standing pain or sitting pain, then I do want to look at that. And again, I don't always use the arms for loading. So if the patient's got just pure standing pain, you can just load from the top like what we did. But if the patient is working in a factory, carpenter, moving, with load, then you can load the arms, see again effect on that. And just gives you a direction. Okay, so if anterior tilt is better, then maybe we're going to work through that motor control in anterior tilt. If softening the muscle relaxation is better, so we're going to look at the teaching strategies for that relaxation. But then you guys are going to go more detail when we look at the motor control. But this is not diagnosed with just quick screening, because the patient reported to me that sitting is a problem, or maybe standing is a problem. So the next thing we can look at movement, isn't it? So we can look at the active range of motion, flexion or extension or side bending, or what the patient complains of. And remember, with this in acute or subacute stage, I can do repeated movements, either repeated flexion or repeated extension, to see that centralized the movement. Okay? Now, looking at these guys, if you look at the bottom picture, so both patients can flex forward. They can reach almost around similar, from the floor, similar height. But how they move is different, can you see? So the guy uses thoracic and lumbar, so he's probably at the end range of his flexion. But he can't go any further, probably because of the tight of the hamstrings. So he's got more sort of a lumbar thoracic movement or pattern, whereas the girl, as you can see, she's got hip strategy. So she's flexing the hips to bend forward, but the lumbar spine stays in extension. And they typically, if you think about it, if you're always flexing through the hips, keeping lumbar in extension, it's a lot of tension in the back, because muscles, what you want to do with the muscles, you want to relax and then activate. Relax and activate. And for this pattern, probably she's always, the muscles are on tension or activated. Yeah? So we can have a look at that. And the same for extension, this girl, she sings when she's extending, she uses the hips and lumbar, and that's normal. You want hip extension followed by the lumbar. And the sway back people, what they normally do, they just drop into that extension. They have no extension in the higher lumbar or even lower thoracic. So they just that hinge in that lower lumbar. So observe the movement as well and see that cause the pain. So this study was done by Rob Laird, and he subgrouped of patients of lumbar pelvic flexion kinematics with and without persistent lower back pain. So he had 266 patients. And so you can see that when these patients moved, they have different strategies how they moved. One was a standard move. So in that group, they had only 26% of patients with back pain. So they contribute from the hips as well as lumbar. The lumbar dominant, so like that guy, so he flexed a lot in the lumbar, but lack of contributions from the hips. So they had 54% of patients that group, so it's like this. So lumbar dominant. Now, pelvic dominant is like that girl, so you flex a lot in the hips and less in the lumbar. Okay? So everybody got different sort of strategies. And so in that group, they had 83% of patients with back pain. But the worst group was the ones who were guarded. And what I mean by guarded, the ones who had a lot of core contraction. And to be honest, like again, I'm keep going out myself about my back pain. I think I really so much activate my abdominals, like as a protection kind of response, that I was almost getting stomach pain and almost going into my groin. It was crazy. I really suffered the last few days. So these people, what happens when they have this guarding, could be acute, could be chronic guarding, is they had less variability in movement. Movement is slower. So in that group, the ones who regarded, all of them had 100% of back pain and least relaxation. And it makes sense, isn't it? When we have back pain or even neck pain, how do we move? Slower, more apprehension, and always more guarded. So in fact, what that does, increases the load on the spine, on the neck could be, on the lumbar spine as well. So we just observe, how the patient moves. But really, really commonly you will see this. But when we don't have pain, we don't even think. When we feel, we twist, we go quickly, faster. And that's why when we look at the rehabilitation, not only we want to improve range, but sometimes we want to improve speed, especially in the neck. When we cross the street, what we need speed. So not only the range that we try to increase, but also speed of movement. Okay. So when we look at the assessment, I typically ask them, tell me what is your resting pain like before they move, because I want to see what happens as they're moving into flexion and what effect it has on pain. Okay. So if you look at those two patients, so they both go into flexion. Guys, yeah. And have a look at difference between just movement pattern. Yeah. Okay, show you one more time. So you observe the difference between the guy and the girl as they go into flexion. Okay. So what do you guys see? Yeah. Maybe the speed of movement. But also you can see this guy certainly doesn't have movement impairment. In anything, he's got a lot of movement, isn't it? In the thoracic, in the lumbar, he's definitely not stiff. Yeah. So probably manual therapy wouldn't need to do in this patient. When he had pain through range, like painful arc or control issues, so maybe we need to look at the motor control. The girl, you can see that even though she can touch her floor, but her spine is still in extension a bit more. So she uses more the hips, but maybe she cannot relax the back muscles or extends at very hypertonic. Okay? So it's just seeing the difference, how they can still almost reach the floor, but how they do it is a bit different, isn't it? So you see the guy here again with back pain. Again, I almost can feel his pain. So as he's going forward, you can see that what he does, he flexes through the hips, keeping the lumbar in extension. So again, muscles are switched on all the time. And what normally should happen as you flex, the muscles working eccentrically, they're working eccentrically, at some point they switch off. Peter Sullivan did a study with chronic low back pain. Commonly, not everyone, but commonly what you see, as they flex, the muscles are working, they're working. At the end of flexion, they do not switch off. So you can imagine if you're not switching off, it's causing almost hypoxia in those muscles, isn't it? Changes pH, sensitizing chemical receptors or nociceptors. So we want the muscle to contract and relax, ability to contract and relax. So that's, yeah. Okay, that's just another postural. Okay, guys. Now for extension, again, normal movement, or how we observe that you extend the hips followed by the lumbar extension, isn't it? And you get around 10 degrees of hip extension plus lumbar extension. Some people, what they do, they have no idea, they don't use the hips. What they do, they extend only the lumbar. They don't go hips and lumbar. So observe that. Because if you don't utilize your hips, then you're increasing the load on the lumbar segments, typically L4, 5, L5 is 1. If you've got a sport that requires the extension of the lumbar, like tennis, and you're only doing it from the lumbar. So we want to make sure that they're utilizing the hips as well. So don't forget to look at the hip mobility as well. And if you look at this guy as he extends out, guys, so you can see all he does hinges in the lumbar spine. No, really
hip movement. One more time, we'll show this video. So he extends only in the lumbar, minimal hip. And so overloads potentially compressing the disc, facet. Yeah. So observe that.
Like this kind of patient, when they overload, is it at the joint that doing the movement or at the lower compartment like FIS or region?
So it depends, so if you want to be specific, you could look at your islet crest. When you look at the islet crest and go in the middle of a spine, so it's usually L4, L5. So you can have a look, is it more there or is it lower down? But this still, I think, what we need to do next, we'll look where the pain is coming from. So I would push on the joints. So then we make a decision, is it more that L4, L5 is sensitized? Maybe L5 is one. So this is difficult to see from this, just which particular level they overloading. But for sway back, typically, they just hinge, is L5 is one typically. But we still need to do a bit more testing for that. So guys, I think it's 12:35. And Dean was saying if we finish at 1, then it's going to be lots of people having lunch. Might be difficult to get lunch. Is that correct, Dini? So we'll stop here for lunch. So, and we'll come back in 1 hour, yeah?